Kavisa's been working very hard with me to try and get our link from New Zealand. I'm going to talk to you today about late consequences of the Fontan circulation. And I hope that we are seeing more of these patients who are going further on into their life now, so I hope this is of interest to you. I am sorry, I have obviously a New Zealand accent, and I hope that I'm not too difficult to understand. I hope also you know where New Zealand is. It's a long way away from where you are, right down in the South Pacific. And this is where I am, up in the northern part of our country in Auckland. And we have a children's hospital and an adult hospital that sit right next to each other up here. So I look after here children with heart disease and also adults with congenital heart disease in Auckland. So in New Zealand, we've had just one centre for congenital heart disease surgery, and as you can see, these are all our patients that we have with Fontans. So we have about 265 patients, and you can see here the ages of those. So there are some of those patients that were operated on a long time ago who are getting up close now to 50 years of age, and there obviously are many of them who are still very young. But we take care of now quite a few adult Fontan patients, and this is helping us to learn a lot more about these people and their difficulties. This is a diagram that I quite like from Dr. Park's textbook that talks about all the different styles of the Fontan operation. So as many of you will know now, many Fontans are done with an extracardiac pipe that connects the IVC, the SVC, and the branch pulmonary arteries. But when the Fontan operation started, the earliest Fontans were done for tricuspid atresia, and they were done by joining the right atrium directly on, in fact, to the left pulmonary artery. And they thought initially that you would need to have some valves in the circulation. And so there are many patients in New Zealand and in other countries around the world who have these older styles of Fontans. Many of the old Fontans were originally an atriopulmonary connection. And then more recently, we have a Fontan with a lateral tunnel that goes inside the atrium, sometimes with a fenestration. And then, as I said, many places now will in fact try and do an extracardiac Fontan so they don't disrupt things inside the atrium. So there are a lot of different styles of Fontans, and when you meet Fontan patients, I think it's really important to understand that this is very much an evolving population. So when I see parents who have a young child with a single ventricle anatomy, they say to me, what will this be like when my child is an adult? And I can tell them a bit about what the adults now are like. But obviously how well people do depends on a number of things. It depends on what type of Fontan they have. Some of them have had shunts or Glenn procedures before their Fontan. Some of them had their Fontan done at age 3, and some of my older patients had this procedure done in adolescence or even adult life. Some of them were blue for long periods of time before their Fontan. And then some of them, as I'll talk about, have other issues outside their heart that have quite a big impact on how they do. So this is really a population that changes over time. When a Fontan is not doing well, we talk about a failing Fontan, and that can present in a number of different ways. It can present as blueness or cyanosis. It can present as ventricular dysfunction, either because somebody comes in heart failure or because we are scanning them and realize that their ventricle is getting into trouble. They may have rhythm troubles. They may have protein-losing enteropathy. They may develop clots. They may get combinations of these, and sometimes we see people with various symptoms and signs which show us that their Fontan now is struggling. But one of the things I want you to realize is this is often a gradual process, and that it involves assessing not just the patient's heart, but also problems outside the heart. One of the really important things then about the Fontan population, as with other adult congenital patients, is that you need to recognize that, yes, we assess the heart, but also some of these patients have other congenital disease that will be part of how well they do in the longer term. And some of them, having had a Fontan, will have other issues related to the surgery they've had or complications of their Fontan, and we will talk a bit about some of those. And then some of them will also not be born with problems, but acquire problems over time, which may or may not be related to the Fontan circulation. So we need to think about these people and all of the different types of issues. In New Zealand and Australia, there has been a very big project that has been going on, particularly in the last 2 or 3 years. A surgeon called Eve Dudekim from Melbourne is leading a collaboration where they are looking at all of the Fontans from Australia and New Zealand. And they're doing this for several reasons, but mainly because many places, when they report on outcomes of Fontans, it's hard for them to collect up a very comprehensive experience. They tend to just report on the people they've continued to follow. So what we're trying to do here is to get a whole population of Fontans. So this is the paper that was published in Circulation now about 18 months ago. And these are all the patients who are in this registry, and there are over 1,000 in the registry now. So this is showing you a little bit like the slide I showed you from New Zealand. Here are the oldest Fontans, the atriopulmonary Fontans. And then you see in the 1990s, people are starting to get into doing lateral tunnel Fontans. And then here are the extracardiac Fontans, which are actually now the biggest group in this experience. And I want to talk about this paper a little bit because I think it's got some very interesting things. So what we hope, obviously, with the newer types of Fontans is that people will do better over time. So here is survival for these 3 different types of Fontans. And you can see that the atriopulmonary Fontans, who are this dotted line, certainly over time, their survival seems to be a bit worse than these other groups. One of the tricky things, though, is obviously they are the oldest people, and so when you look at long-term follow-up like this, there are many more of those people who we've got really long-term follow-up on than some of these other groups. So while these curves look quite encouraging, it's quite hard to know exactly how well these newer types of Fontans will do in the really longer term. This is rhythm troubles. So one of the reasons we have newer style Fontans is to try and minimize the number of the rhythm troubles that we saw, particularly with the atriopulmonary Fontans. And you can certainly see here, again, there are reasonable numbers out to 10 years, and already at that point in time, it seems like the curves are diverging, and so we're seeing more rhythm troubles in the atriopulmonary Fontans, some in the lateral tunnels, but the least in these newer style of extracardiac Fontans. Here is a whole group of adverse events that we might see in the Fontan population for the group as a whole. And I guess this is a little bit more concerning, particularly if you were having that conversation with the parents, because what you see here is that if you look at freedom from adverse events, as you get 10 years out from your Fontan or 20 years out from your Fontan, there are more and more of these kinds of troubles. Obviously, we hope with more newer style Fontans that this curve will move up a bit, but we can't be certain about that. So what are the risk factors for these problems in the longer term? Well, if you have an older style Fontan, an atriopulmonary Fontan, certainly you're at more risk. If you have your Fontan done when you are older, and so I know, for example, some of you in India, you may not meet some of these patients until they're a bit older, and you may need to do their Fontans when they're older, and there is no doubt that that does put people at higher risk. If somebody at the time of their Fontan had prolonged pleural effusions, then they are more at risk. And for some reason, also male sex seems to put you more at risk. And in terms of late Fontan failure as opposed to mortality, those who stayed longer in the hospital, those who had hypoplastic left heart syndrome, and again, the older Fontans were more at risk. This is a paper from the Boston group. It was looking at all of their Fontans who were born before 1985, and I wanted to show you this to really point out some of the kinds of trouble. So don't worry too much about these perioperative deaths, because we're talking today more about late follow-up. But in terms of why people die late on after their Fontan, here are some of the reasons. Some people die suddenly. Some people die from issues related to clot, and obviously in this circulation you can see clot in the Fontan, you can see strokes, you can see clots in ventricles, you can see clots out in the lung. Some patients get heart failure, and some people had sepsis, and there were some other deaths in this group as well. So that's a little bit about where we're up to with mortality, but what about morbidity? Well, one of the big ones that we worry a lot about is arrhythmia. And again, this has been particularly a problem in these older style Fontans, and we hope that things will be better with the newer styles. But arrhythmia really can be divided into three broad categories. We get atrial tachycardias of various sorts. We get slow rhythms, bradyarrhythmias. Again, we hope the incidence of those is going to decrease with these newer types of Fontans. And then studies would show that in 3 to 12% of these patients in late follow-up, we can also see ventricular arrhythmias. In many adult congenital series, we worry about the risk of late sudden death, and you do see a bit of this in the Fontan population, but the number is pretty low, so estimated to be about 0.15% per year. This was a study, a review actually from Barbara Donnell, who's a doctor some of you may have heard of. She is in Chicago. She's an arrhythmia EP expert. And she wrote a review in terms of atrial arrhythmia in the Fontan, looking at when the hazard occurred. So here you are. This is obviously there are some early rhythm troubles, and then things seem to settle down. And then over time, you get this increasing hazard for intraatrial rhythm troubles. And this is, again, a bit similar to what I showed you earlier, that seems to be predominantly in the atriopulmonaries, but again, we've got fewer numbers of the other types of Fontan out this far. What did she say that they did for these rhythm troubles? Well, they tended to assess these patients with hemodynamics, with imaging, with a functional assessment, and also metabolic markers. And if you look at her paper, they then make a decision about whether people might receive medical treatment or possibly a catheter ablation. If people are not doing so well and they have got an older style of Fontan, you might think about converting them to a newer style. Again, if people are in more trouble, Fontan conversion, and for some of these patients, the only potential considerations were medical therapy or heart transplant if they're really in big trouble. This is from the UK, showing us a similar thing in terms of follow-up and atrial arrhythmias. Age 29, tachyarrhythmias in 42% of their adult Fontan patients. So moving away from arrhythmia, there are, of course, other issues in this population. If you put these people on a treadmill, this was very, very nicely demonstrated now almost 15 years ago by this work, which showed a VO2 max in the Fontan population compared to a reference population, and showed that all of these patients really had quite limited exercise tolerance. And certainly, if you had had your Fontan at an older age, your VO2 max at this follow-up study was lower. What sort of lung problems do we see? Well, there are several papers, including that last one I showed you, but it's been shown that this group of patients seems to have a number of issues with their lungs. They have scars on their chest, they have a level of restriction in their lung function, they have a decrease in their diffusion capacity, and they have an increase in their residual volume. So certainly some of their exercise limitation is related to their lungs. But not all of it. There are a number of other factors that come into play here. Obviously, if you've got impaired ventricular function, that's going to impair your cardiac output. If you are blue, if your heart rate response is limited, and also if you are relatively deconditioned. So I think we've certainly made the error with many of our complicated heart patients in the past of discouraging people from exercise. And I think it's incredibly important that we do encourage people to do some conditioning exercise. And I often talk to the patients about this not all being about their heart, it's also about their lungs, it's also about their muscles. Changing again to another issue that we do see from time to time of protein-losing enteropathy, and I'm sure many of you have seen this. It's a very worrying problem. It is undoubtedly associated with poor hemodynamics, but we don't know why some patients develop this and other patients who have failing hearts don't develop this problem. And as you will know, there are a whole number of treatments that have been used, which usually tells you that none of these treatments work particularly well. So certainly people have tried steroids, octreotide, heparin, sildenafil, spironolactone. Sometimes if people don't have a fenestration, people try and create one, and this is somewhat of a last resort in this situation. Clot. How much clot you see in Fontans depends really on how hard you look for clot. There are some risk factors, so certainly these older style Fontans with the great big dilated atria and the atriopulmonary connection are more at risk, but other patients also can have clot, and these are the types of things that put you at more risk. So if you've got higher venous pressures, if you have protein-losing enteropathy, rhythm troubles, stenoses in your Fontan baffle, a lot of prosthetic material, clotting problems, and if you're not using any anticoagulation, you are more at risk. What do we know about what happens with clot? Well, we know that anticoagulation definitely decreases the incidence of clot, and that goes for aspirin and warfarin. And as you probably know, it's been very difficult to demonstrate a clear difference between patients anticoagulated with aspirin and warfarin, but we know that no anticoagulation is a bad thing. And also that once you've got clot, that's definitely a marker for trouble. There's a nice adult congenital series from Toronto that showed that in their Fontan patients, even with their aggressive care, they showed an 18% mortality in people detected as having clot. So it's a bad thing to have. I wanted to spend a little bit of time talking about the liver in the Fontan circulation, because this has really become a big issue in the last few years, and we don't really know what to do about it, but it's important that you recognize this as an issue. So what we're increasingly recognizing is that these people are gradually, these Fontan patients are gradually developing problems in their liver, and that if you start to image the liver, as you get further out, particularly more than 10 years out from your Fontan, you get into more trouble. What are we worried about? Well, it seems very much that these patients develop chronic congestion in the liver. They then develop often fibrosis, which can turn into cirrhosis, which can turn, in a few cases, potentially into risk of hepatocellular carcinoma. So it's a pretty worrying situation. It's been known about for some years, it turns out. There was a paper in fact, the 1980s that reported a girl who'd had her Fontan, I think, at the age of around about 8 or 9, one of these older style right atrial, right ventricle Fontans, and she was found to have developed cirrhosis 5 years after her Fontan for tricuspid atresia. So as often happens, that was in the literature, but I think not really understood by many people. And then over time, it became increasingly apparent that you did find these abnormalities of liver function and clotting and albumin in the Fontan population. This is a paper from Barbara Mulder's group. She's a very good adult congenital doctor who leads a big group in the Netherlands. And this is a study from the late 1990s looking at Fontan patients with a mean age of 18. And you can see some abnormalities detected in bilirubin and in albumin, but obviously not in all the patients. And when they looked more across the board at liver function, you could certainly find patients with various kinds of abnormalities, although certainly they weren't universal, and there was no one particular thing that seemed to stick out as an important marker. I just want to warn you, this issue is really complicated, and it is a little bit of a can of worms when you start to think about it, because there are a whole number of questions. If we know that these people can develop fibrosis and cirrhosis, when should we start to screen for that, and how should we start to screen? When should we be sending these patients to see the liver team? I certainly from personal experience can tell you that a lot of my adult Fontan patients know they've got a major problem with their heart, but when you sit them down and say, look, we've done a scan and we're really worried you're developing cirrhosis, it's a huge thing for them. And we need to try and figure out when we need to get the liver doctors involved. We also, at this point, don't really know, apart from trying to optimize their hemodynamics, we don't really know how we can try and solve this problem and exactly the impact of these changes on anything else we do. So, you know, once a patient has got fibrosis, what exactly is the impact of that in terms of other interventions we might like to do in terms of surgery or cath lab or big procedures like a transplant? There are quite a few papers, and I've just put a few of them in for you. There was a paper that was published a few years ago now. Grushin Veltman, who's now in the US, published this with his colleagues from Southampton, and they were looking at adult Fontan patients with these older style Fontans who were coming for potentially to have their Fontan upgraded to a newer style. These were people in their 20s, and they gave them a comprehensive assessment, including a liver biopsy, and they found, in fact, that a lot of these people had cirrhosis. They did a catheter and found that there wasn't a very big difference between the hepatic vein wedge and the hepatic pressures, but that these pressures were a bit high and higher if you had varices and cirrhosis. They found in some people, but not everyone, you had abnormal liver function tests. And certainly if you did a CT, you found a lot of abnormalities. So you found liver nodules, hepatomegaly, big spleens, collaterals of various types, and in some people varices. This was another paper from their group just showing you what these kind of arterialized nodules look like inside the liver on CT. And another paper looking at the liver biopsy data from this group, from a slightly larger group, showing a lot of fibrosis, cirrhosis, and other really important findings in this group of patients. So they concluded from this work that patients with a long-standing Fontan circuit develop liver fibrosis, although some of it perhaps might be reversible. This is from our colleagues in Korea. Again, just looking at quite a large group of Fontans, mean age of 19, and finding a very high rate of liver complications if you start looking with things like CT. And certainly in their study, when they looked back, they found that the sorts of things we would worry about in terms of the Fontan not working so well certainly seem to contribute to the risk of having these liver troubles. And also, particularly, how far out you were post your Fontan. This is some pathology data, again showing similar things, but this work demonstrating from various authors that these changes seem to go from congestion to cirrhosis, and in a few cases to adenoma, and as I say, there have been case reports, in fact, of carcinoma in this setting. But interestingly, what they pointed out in some of this work was these changes might even in some patients precede the Fontan. So this is a post-mortem study of patients who died post-Fontan, and you can see very young Fontans. Mean interval to death was 20 days, so these are patients who died, they had Fontan at a young age and they died often very early, and many of those patients already had fibrosis, including some who died less than 30 days post-Fontan. So that raised the issue of whether some of this liver stuff even pops up before the Fontan. So why does this happen? Well, the liver in somebody with a normal heart takes about 25% of the cardiac output, and a quarter of this is fully oxygenated supply that comes through your hepatic artery, and you've got the ability to auto-regulate that. But actually, most of it is deoxygenated blood that comes through the portal vein at venous pressure. So there's no auto-regulation of that part of the circulation. So about a quarter hepatic artery, most of it comes through the portal vein. And the theory in the Fontans is that potentially the Fontan pressure goes up, that these are people with a limit to cardiac output. So maybe the portal vein flow, which is passive, goes down. It's relatively blue blood, and then you become very reliant on this hepatic arterial supply to auto-regulate to improve your flow. But nobody is really, this is sort of speculation at this point. I don't think we're really confident on exactly what's going on here. In a Fontan patient, obviously you get other times of physiologic stress. So times when they're sick, they might have low cardiac output, they might be more blue, their venous pressures go up, and maybe also there's more in the way of liver infection in this group. So this is another article in Pediatric Cardiology, again, trying to sort out what sort of insults in this population might be leading to these changes in the liver, which can eventually lead to cirrhosis, including traditional risk factors for liver troubles, cardiovascular risk factors, and then maybe some other factors that potentiate this and make things worse. How can we assess this? Well, we can do our traditional things. We can look, as you would in other patients with portal hypertension, for thrombocytopenia, hyperbilirubinemia. Maybe some other markers are helpful, but we don't really have a good grasp on that. And various kinds of imaging, ultrasound, CT, MRI, have been discussed by a number of people. We tend here just to start with an ultrasound. Nobody yet knows there is this thing called a fibroscan, but that also tends to be abnormal just if your liver is congested, and many of these patients will have congested livers, if not all of them, so we're not really sure how helpful that is as yet, and we're not really sure what the role of biopsy is. I realize I'm spending a lot of time on the liver, but I guess that's been a really big deal in the last particularly 2 or 3 years in this population. And one other paper I wanted to mention, just if, you might think about, well, maybe some of the other liver scores people use in other patients are helpful. And certainly that's been raised by the Boston group, looking at this thing called the MELD score. The MELD score would potentially include INR, but if you're anticoagulated, obviously that's not that helpful. But there are some papers looking at these other kinds of scores and whether they will be helpful in these patients. So there's a whole lot of complexities to this. We don't really know when to screen or how often we should screen. We know we need to start talking to our liver colleagues, and we know we need to try and make these patients as hemodynamically optimized as possible, but we have a lot of remaining questions. So what about these people who have old-style Fontans and converting them to newer-style Fontans? There are quite a few papers on that. The largest experience is from the group in Chicago, and that you can have a look at their papers. The indications that people tend to use are people who've got really dilated atria who are getting a lot of atrial arrhythmia. Sometimes they've been on amiodarone for a long time and they're getting into trouble with that. Sometimes clot. When people are running out of steam and getting reduced exercise tolerance. For some people, the atrium gets so big that it presses back on the pulmonary veins, and so that obviously causes problem in a Fontan circulation, PLE, ascites, rhythm troubles, and often there are several of these things going on. I think what we've found locally is that certainly you shouldn't wait too long, that if you really wait till these people are in low cardiac output and very sick, they tend to not do as well. So we certainly in our program have tended to operate on these people when we start to see a couple of these things come together. A couple of other things before I finish that I just wanted to mention. So in terms of other morbidity in this population, there are some things you might not think of. So this study came out now a few years ago, looking at disease in particularly the leg veins of Fontan patients. What they did was take some adults with Fontans, some adult tetralogy patients, and some healthy controls, and they compared those people in terms of symptoms of venous insufficiency. And you can see here that actually in the Fontan population there was a very high incidence of symptoms, and in the tetralogy population, in fact, many of those patients also had symptoms of venous insufficiency in the legs. You can also see, interestingly, that many of our adult Fontan patients and our adult TETs have had quite a number of catheterizations, and undoubtedly this has had some contribution. Well, you might think, okay, well, they've got somewhat distended veins, but as you'll see from the images in their study, these problems can be pretty profound in some people. They can certainly get problems like, for example, venous stasis ulcers in their legs and get a lot of disability and discomfort from these problems. Who gets the problems? Well, certainly, again, for some reason, the males seem to do less well. The older patients do less well, and the older styles of Fontans. But again, you just need to bear in mind the older style of Fontan, the patients tend to be older now. So, you know, it doesn't mean to say we won't necessarily see these problems in the newer Fontans. If people have had a preceding clot, that's important, and if people had had a whole lot of catheterizations, then that's also a risk factor for these venous problems in the legs. So that was most of the issues I wanted to raise with you, and I'm very happy to take questions, but essentially what I wanted just to demonstrate is that many people are doing well with their Fontans in terms of survival in the modern era. But I think, like so much of congenital heart disease, this is a story that continues to evolve, and that this group of patients, you will see different issues arise in the different patients of different age. Everybody has their own story and was operated on in a particular time frame. There are a number of late consequences, and they include both heart and non-cardiac problems, and we've talked about some of these, including arrhythmia, heart failure, clot, lung disease, PLE, liver problems, and venous insufficiency. I haven't talked a lot about renal disease, and we don't have a lot of data on that, although quite a detailed renal assessment is part of this latest Australian-New Zealand study, so there will be some more work, I know, coming out on that in the fullness of time. So what I really, if you only took away one thing from today, I guess what I'd really like you to understand, I know most of you will be pediatricians, if not all of you, and you will see these patients in childhood, but I really want you to take away that these patients are definitely going to need long-term follow-up. And certainly we need more people. I come from a pediatric background and also do some adult congenital heart disease. And if you're interested in looking after these children, we certainly need more people also, both from adult cardiology and from pediatrics, who are prepared to take an interest in how this story is going to unfold in longer-term follow-up, and try and persuade these patients to keep coming to see us. Thanks very much. Okay, I'm very happy to take questions, guys. Do you put a fenestration in all your Fontan patients? No, we don't put a fenestration in all our Fontan patients. We very much have a look and see if we think there are any risk factors for late problems. And if we do think that there are risk factors, so for example, AV valve regurgitation, ventricular dysfunction, high PA pressures, then we will fenestrate, but it's the minority of patients who get fenestrated here now. Right, so anticoagulation. We locally have tended to be a place that has used warfarin. So patients go on to heparin immediately post-Fontan, but then they go on to warfarin. It's interesting, certainly in Australia, most centres have used aspirin rather than warfarin. And we, certainly in some of my teenage patients, if everything is looking good, or in some of the children, if they're having problems with warfarin, I back off at times to aspirin. But in the adult Fontans and the older Fontans, who I think are having more issues and are more prone to clot, sometimes we have to talk about going back on warfarin if things aren't going so well. Okay, and I see a question there about dietary modification in post-Fontan patients. In general terms, I think that, people should just be encouraged to pursue a healthy diet. But obviously, if so you obviously don't want these people to get too heavy. So they should just be having a healthy diet. But obviously, if you have particular problems like PLE or liver dysfunction, then you may be needing to have specific things in the diet. In some of these patients, we have to increase the protein. But in general terms, I just encourage them to have a healthy diet. I see a question there about the role of MRI on follow-up and how frequently should it be done. So that's a good question. Obviously, not all centres will have good cardiac MRI for Fontans. And obviously, some patients will have a pacemaker, which means that we can't use the MRI. We tend to, in patients in New Zealand, I will often get an MRI around about the age of 10, because at that point in time, we can do an MRI without general anaesthetic. Obviously, if there's issues earlier, we can get an MRI, we just need to do a GA. And then in my adult patients, if they are able to have an MRI, often about every 3 years thereafter, I will send them for an MRI, really to have a good look at their ventricular function and any other kinds of issues, but it's a little bit individualized. How do you manage persistent pleural effusions? That's a really difficult problem. Now, obviously, it depends on how early you are talking, and it depends on whether you have chylothorax or whether you just have an effusion. So we will assess and see in the early days after a Fontan whether we think we've got chyle or not, and if we have chyle, then we change the diet in terms of the lipid content of the diet. We also tend to use quite a lot of diuretic and sometimes ACE inhibitor. We try and move forward, but if at 3 weeks we've still got effusions, we've maximized medical therapy, then we will sometimes go and do a catheter, check the pressures, and see if we have anything that we can coil in terms of collaterals to try and help. But sometimes, as you know, it's difficult, and I'm sure particularly when you see some older Fontans, it can be quite difficult. Risk factors for PLE. Well, I mean, most of the things that would describe failing Fontans would be risk factors for PLE. I think PLE is a really interesting condition, but if you find that somebody's got high Fontan pressures, ventricular dysfunction, AV valve regurgitation, those are risk factors. But as I say, not everyone develops it, so it is obviously a more complicated condition. And there's very interesting work being done in the US. Philadelphia has got some ways now to try and image the lymphatic circulation, which I think is going to teach us quite a lot about PLE. Plastic bronchitis I didn't talk about. So the other question was, how would you manage a case of plastic bronchitis? And I didn't talk about that specifically because it's very rare. And to be honest, I mean, I saw one case when I was in Boston. I have not seen another case in New Zealand. And so, I know that people have used, nebulized things to try and break up the casts and stuff, but it's a very difficult thing to manage, and it's not something that I've done of recent times, so I'm not probably a really good person to give you a lot of information about that. Most adult patients, single ventricle cyanosis, have thrombocytopenia, raised bilirubin. Should these patients be scanned for pre-existing fibrosis? So I think now that adult Fontan patients should be having liver imaging, and I think nobody quite knows exactly what the best test is, but I think what we are doing is certainly sending people for an ultrasound, and I think that will tell you a bit, and then they should also be seen by one of the liver teams, but obviously what you're looking for is fibrosis, potentially cirrhosis. It depends, you know, as I say, the data would certainly say that the further out from your Fontan you are, and certainly 10 years out, many people are starting to develop changes in the liver. It would be really interesting to start to look, because I know you have some patients who've had Fontans done at an older age, and whether those patients develop this problem faster or slower than people who've had their Fontan done in childhood would be interesting. But I think now all of these patients, we have to start to look at the livers, and as I say, the simple place to start is an ultrasound. If you have capability to do MRI and you can get those people to scan down onto the liver and you've got somebody to read that, then that's another simple way. I don't think we want to be doing a whole lot of CTs on these patients. Role of BMP on follow-up, that's a good question too. The short answer is I don't know. I've tended to use BMP. I mean, I don't know what you get told, but we get told here in this hospital that BMP is quite an expensive test, and so I tend to use BMP when I'm trying to track something that you know, for example, if I'm looking at subtleties of a ventricle and I think possibly we're getting into trouble, but I don't really know, then I might check a BMP. But we don't regularly send BMP on this group of patients. I think it's, if you can tell from other clinical signs and symptoms and what you see on scan that the patient has a problem with the ventricle, I'm not sure whether BMP is going to help you to do something differently. But sure, if you're following somebody with heart failure and everything else seems equal but you're worried, then you could certainly do a BMP. The next one says, have you encountered conditions with normal Fontan pressures and recurrent effusions after excluding hypoalbuminemia? I guess the answer to that is no, except that, you know, I know we've had, for example, one child who had an interrupted IVC and has got low pressures, but ended up having a Fontan or having a Glen, which effectively is a Fontan at quite a young age, and has had a lot of problems with effusions with fairly low pressures, which I think probably relate to collaterals in her chest. So, yeah, I think, you know, in that situation, I'd probably be looking for aortopulmonary or venous collaterals, potentially. At what stage would you go for cardiac transplantation? Now, that is a really difficult question in this population, and it's one that people debate a lot. And it's becoming even more complicated now because of these liver issues, because many of these patients who are waiting may be quietly developing cirrhosis. In the past, we would certainly, it would be heart generally, not heart-lung. But I think certainly in our country there is a big shortage of donor organs, and many of these patients can do quite well as Fontans, as you saw in the follow-up, in their 30s and 40s, even though they're limited. So I think it's quite difficult. Certainly if we see that people are getting into failure of the types that I mentioned, if they've got a newer style of Fontan, if we haven't really got anywhere else to go. But again, the problem that you get into is if people are too deconditioned, they have, for example, a very low albumin, if they have liver changes, they have other problems, then actually their chances with the transplant will not be all that good. And certainly in this country, the problem is we have so many people waiting, then do you take someone who's a poor candidate versus someone who might be a better candidate? So it's a good question, but it's a hard question. What is the definition of persistent pleural effusion? Look, I don't think there is a set definition. I think it depends a lot. You're talking probably, I guess, about somebody who's post-op of Fontan, and as I said, we would usually cath, in our case, usually it's children, we would cath them at 3 weeks and say at that stage that we have a persistent pleural effusion, but I don't think there is a strict definition. And then Vicar said, how old is your oldest patient? So as per that thing that I showed, our oldest Fontan is coming up on 50, but I know that we have, I certainly in Boston looked after Fontan patients who were in their 50s. And bearing in mind the Fontan came in the early 1970s, but that the first Fontan patients were not children, obviously there will be people around the world, certainly in their 50s, with Fontans. But as I think it's really important to bear in mind, well, those people tell us something about what will happen to our Fontans today. So many things have changed since their Fontans that, you know, we hope that the kids we look after today will be better off than those patients. But we don't know. Okay, so just had a couple more there. What's your current survival rate post-transplant? I don't think it's fair to tell you that. I can tell you we have done some transplants post-Fontan, and certainly some of those patients are still surviving several years out, but the numbers are quite small. So it would be wrong probably for me to count that as a statistical rate. But there are some papers on Fontan transplant survival that I didn't put in for you, but you could certainly look that up. Yeah. Someone said how many years. I'm not quite sure. Yeah, how many years they survived. Yeah, as I say, we've certainly got people who've survived a few years, but I can't tell you exactly how many years off the top of my head. All right. Well, look, it's been a great privilege for me to talk to you all, you know, I do wish you all well with your hard work. I know you're just starting your Monday morning. I'm coming towards the end of my Monday, but thank you very much for tuning in. It's been very nice to speak to you.
Thank you very much, Claire. This is Sunita here. Thank you. That was a lovely talk. Thanks so much.
Okay. Take care now. Bye now.
Okay. Bye-bye.